I'm going to talk about recognizing, assessing, and treating psychoses in the elderly, and I'm going to emphasize our work with Alzheimer's disease, but I'll try to put this into a larger framework so that we address all of the issues, or at least most of the major issues relevant to psychosis in elderly individuals. I'll do this by, first of all, addressing the etiologies of psychosis in the elderly, what are the causes, and really, I'll give you the bottom line right now. When you see a new onset psychosis in an elderly person, think about a neurological or medical or toxic illness. By and large, the idiopathic illnesses begin early in life, and the symptomatic or secondary psychoses begin late in life. So if there's one message to take away from this lecture, that's it. Then I'm going to review the characteristics of psychosis in the elderly. I'll talk just a little bit about pathophysiology. In truth, we don't know quite why people do get psychotic, but there are some interesting anatomical and biochemical hints about how this happens. And finally, I'll talk about treatment, both the conventional agents and the novel antipsychotic agents which have been evolving. So, I guess I must have changed the slide order here. So we'll start with characteristics, and then we'll go to etiologies. So characteristics, I think you know quite well. Psychosis is really defined by the presence of a delusional disorder. That is a false belief, frequently accompanied by hallucinations, which would be either visual or auditory. In the organic psychoses, they are often visual. In the idiopathic psychoses, they are more likely to be auditory. In the neurological disorders, a thought disorder is rare, and therefore it's rare to see a new onset thought disorder in an elderly individual. Okay? Thought disorders are characteristic of schizophrenia, where one can see the illogical thought, the clang associations, the loose associations, circumstantiality, tangentiality. Those are aspects of thought disorder. That is rare to occur as a new onset phenomenon in an elderly individual. So we rarely see it in this context. And the other important thing I'd like to draw attention to is the presence of agitation and aggression in psychotic individuals. When you look at what are the features that characterize psychosis in an elderly patient, it's not just that they have false beliefs. It's that they have false beliefs that they are acting on, and therefore this is very disruptive to the care setting, be it family or a hospital or daycare, whatever it is that they're in. So this is a particularly important dimension of management of these patients. Now, just a couple of definitions to make sure that we're talking about the same things here. Delusions, false beliefs held despite evidence to the contrary. And in the illnesses that we'll be talking about, basically we see two kinds of psychotic phenomena. One is a sort of a diffuse persecutory belief system or paranoid ideation in which the patient sees someone and immediately feels, oh, you're looking at me in a very strange way, and you got your hand up, you must be threatening. I can see you got a fist now. Oh, this is terrible. You know, I'm really threatened by your presence here. That's one kind of thing, and that can be focused on any individual, can occur at any time in the environment. The other is a set of very focused beliefs that can be the manifestation of psychosis. A focused belief, a common one, are the misidentification syndromes, where the patient has, for example, Capgras syndrome, and begins to believe that someone important, usually the spouse, has been replaced by an identical appearing imposter. And very concerned about this person, that they're not really who they claim to be. Why are they doing this? What happened to my real wife? Those are the kind of concerns, but they're all contained in one encapsulated belief. So that's the other kind of psychosis that you'll see in elderly individuals and in neurological circumstances. The characteristics of the delusion do not allow you to distinguish an organic from an idiopathic psychotic disorder. They can be identical. Hallucinations, of course, are perceptions without the appropriate external stimulation. Again, the old saw that visual hallucinations are more characteristic of neurologic disease and auditory more characteristic of psychiatric illness is true, but is only very relatively true. And you'll see plenty of Alzheimer's disease patients, for example, who have auditory hallucinations and no visual hallucinations. So while it's a kind of conditioning factor in your thinking, it is by no means an absolute rule that you should consider. The other is the important recognition that hallucinations can occur in the absence of psychosis. That is, if one knows that they are hallucinating, then they're not psychotic because they're not endorsing it as a false belief. This happens, for example, all the time in migraine, right, where a fortification spectra occurs in the visual field of the individual. They can see a hallucination there with colored lights and scintillations, but they know it's a hallucination. They know that they're having a migraine. And so, although it is a full-blown hallucination, fits all of this definition, it's not part of a psychosis. So there are two types of hallucinations that must be kept in mind. One is without a psychotic disorder, and the other is as part of the psychotic complex that occurs in conjunction with a delusional belief. Both will be seen in the elderly individual, particularly because visual hallucinations frequently are co-occurring with blindness. So anytime that there is visual deprivation, the elderly individual may well have associated visual hallucinations. They'll usually not be psychotic. All right, now let's think about having thought about what these things look like, let's consider the etiologies. And I'll just briefly review the idiopathic causes of psychosis as they're classified in DSM-4, and then some important toxic and metabolic causes of psychosis in the elderly, and then finally some neurologic causes of psychosis in the elderly, emphasizing our own observations in Alzheimer's disease. So if we take DSM-4 and say, what are the idiopathic psychotic disorders? And if you look at the way DSM-4 has approached psychosis, basically there are a group of psychotic disorders that are idiopathic, and then there are the due-tos. You know about the due-tos? The due-tos are psychosis due to, and then you fill in the blank. Epilepsy, Alzheimer's disease, stroke, Parkinson's disease with therapy. So most of this lecture is going to be emphasizing the due-tos. But there is another group of psychotic disorders here that are regarded as idiopathic because we don't understand exactly what causes them. So the first group is schizophrenia, and it's often called paraphrenia when it has a late onset. There was a debate about whether schizophrenia could ever occur as a new onset, late onset phenomenon. And I think that debate is now resolved in favor of the idea that there are a few late onset schizophrenic disorders, also called paraphrenia. So these patients function well throughout life, then have the late onset of a psychotic disorder. When well worked up, no alternate etiology is found. Delusional disorder refers to a very interesting syndrome that does tend to occur later in life, usually starts off after the age of 40 or 45, and usually has a very circumscribed kind of set of beliefs. It'll be the belief, for example, what are the kind of things we've seen? That someone moves into a house and then believes that there's some chemical that is gradually poisoning them in the house, and this becomes completely dominant. When they go outside, they feel fine. They do not have paranoia that spills over and that they endorse in other belief systems. But every time they return to the house, they have this single focused belief that they're being poisoned. They'll move to the next house, and again, the whole belief system will gradually be recreated in the next house. That's typical of the kind of delusional disorder that you'll see. Then there are a group of other disorders that are less in the differential diagnosis of psychosis in an elderly individual, including schizoaffective disorder. These are patients who have features of both schizophrenia and an affective illness, usually begins early in life. There are brief psychotic disorders that tend to be situationally determined. There are so-called shared psychotic disorders. This is used to be called folie à deux, in which the one person has a psychotic disorder, usually schizophrenia or delusional disorder, and the person who is closely associated with them, usually the spouse, gradually begins to believe the same thing. So in the setting, for example, of the poison rug, or the poison house, the spouse gradually says, yeah, I don't feel quite as well in this house as I used to, must all be true. So then they begin to share the belief system. As soon as that person is separated from the true psychotic member of the dyad, that person, then the non-psychotic person again resumes a non-psychotic state. But it's a very interesting phenomenon that you can, with close association, begin to share the delusional disorder. And then there's something called psychosis not otherwise specified, in which the patient doesn't quite meet any of these criteria. My main point is with this slide is that while paraphrenia and delusional disorder are idiopathic disorders that can occur late in life, by and large they should be approached and thought of diagnostically in an elderly individual only after the toxic, metabolic, and neurologic causes of delusions have been excluded. So the first thing is to approach brain function. All right. Let's consider then some characteristic of the patient who has psychosis due to a metabolic disorder. So this is the first due to. First of all, these patients often have evidence of a delirium manifested by reduced attention. The sine qua non of delirium is an inability to volitionally direct sustained attention. Our test for that is usually the digit span. So we say to the patient, I'm going to give you a series of numbers. When I'm done, I want you to repeat the numbers back to me. And then in your most boring, monotone, 1 per second voice, you say 9, 1, 4, 0, 7, and see if they can repeat that back to you. And a person with normal attention has a digit span of at least 5, and really, in my book, needs to have 6 in order to be fully attentive to you. They can do 6 digits forward in just the way that I've said. Do not use your telephone number because some of these patients will remember it. Although it is a convenient set of numbers to remember, I recommend against it. Visual hallucinations, very common in delirious states. These are the patients who look out the window and see things out the window. They see things going past the door. They look at a picture and they'll see that picture participating and moving and doing things. So visual hallucinations and illusions, very prominent in these metabolic disorders. They tend to have persecutory beliefs, and these can be highly dangerous. So one of the great tragedies that occurred while I was a resident was a patient who had a psychosis as part of an alcohol withdrawal syndrome and jumped from the 4th floor of the Boston Veterans Administration Hospital as part of a fear syndrome. He thought people were coming in and going to get him, going to injure him. He felt so threatened that his only alternative was to jump, and he killed himself, of course. So these things can be highly dangerous, and it's up to us to protect patients who are in this circumstance. Fortunately, they tend to be brief and transient and to resolve as the metabolic disorder is appropriately recognized and treated. Substance-induced psychosis, very important, and there are a number of these that occur prominently in the elderly. The one that we are most common with, and like the one I just described, is a syndrome of alcoholic hallucinosis. These tend to be, actually, alcoholic hallucinosis itself tends to be somewhat more chronic. This is a chronic paranoid hallucinatory disorder induced in elderly individuals. What I just described was a withdrawal syndrome with psychosis, very important as to consider in the psychotic elderly individual. And there are 2 drugs that I wanted really to draw your attention to. One is the amphetamines. An amphetamine-induced psychosis tends to be an intensely paranoid disorder in which the person feels intensely fearful. These are almost exclusively persecutory beliefs in which the person feels in intense endangerment and imminent personal harm. So the amphetamines really need to be thought of. There are specific occupational circumstances in which these emerge more than others. For example, truck drivers or other people who need to maintain alertness. We hope not airline pilots, but in the circumstances which maintain alertness, those people tend to gravitate towards amphetamine use. And you have to think about that. Even in an elderly individual who has had a lifetime on the road may well be still using amphetamines. And then there's this very interesting problem of levodopa-induced psychosis in patients with Parkinson's disease. Of course, Parkinson's disease is a disease of the elderly, so all of these patients are going to be aged. And one of the interesting effects of getting a patient's Sinemet dose too high is to induce a psychosis. It occurs in about 10% of patients with Parkinson's disease who are treated. So this is not an uncommon phenomenon at all, and all of us who work with Parkinson's disease patients will see this. The kind of thing that you'll see, I remember a patient that we had managed to induce this in, who believed that the street lights were actually turning as he walked under them, focusing their attention on him. So as he walked from under one street light to the next, he would feel the street light actually turning and watching him as he was going. So that's a world filled with fear, isn't it? That the street lights themselves are watching you. He had his door open, his chair parked right in front of that door so that he could keep an eye on all of the neighbors and what they were doing, because he was so fearful that he was going to be injured by one of the neighbors. So this is an important phenomenon in Parkinson's disease, and we'll return to treatment. It has been a virtually untreatable syndrome, but now with the evolution of clozapine as a treatment alternative for these patients, we're actually much more successful in controlling this. So an important cause in the elderly. Now, another set of due-tos are the neurological disorders, including Alzheimer's disease, and I'm going to expand on that, but also stroke and vascular dementia. In an early study we did, we found about 50% of patients with vascular dementia had had a delusional disorder at some point in the course of their illness, and that is about the same rate that we find it in Alzheimer's disease. The frontotemporal dementias, that is diseases like Pick's disease, about 25% of those patients will be delusional during the course of the illness. So that's another degenerative illness that you'll hear about. Parkinson's disease with therapy, we've just talked about 10% of patients treated with a dopaminergic agent will develop a psychosis. And then finally, there are a number of other less common illnesses in the elderly that can do this. They include a traumatic brain injury, infections such as meningitis or HIV encephalopathy, brain tumors affecting particularly the parietal and temporal structures, and multiple sclerosis if patients survive into the elderly age group. But by and large, it is these common disorders, Alzheimer's, vascular dementia, and Parkinson's disease, which are the three most common neurological illnesses in the elderly, all are associated with psychosis in some circumstances. So let me tell you a little bit about our work with Alzheimer's disease. First of all, what are the kind of delusions that one sees? Well, burglary and theft are by far the most common. The person comes to believe that people are coming into the house and stealing things from them. Personal endangerment is not too uncommon. The Capgras syndrome occurs fairly frequently as the most common named syndrome. And by the way, they tend not to get the whole story. They tend to say, this person is not who she claims to be. She claims to be my wife, and I know this is really not her. But they hardly ever have the cognitive complexity to take the next step and say, and she has been replaced by an identical appearing imposter. That's a really tough step, isn't it? And the patients with Alzheimer's disease do not have the cognitive integrity to generate that. But they're very convinced that this person who is with them is not who they claim to be. Our record case of this is the man with the 7 Lillians. And he had a wife named Lillian who had disappeared. But there was another Lillian who took care of the laundry, a Lillian who did the dishes and served the meals, a Lillian who drove the car, a virtual harem of Lillians that looked after his needs. And although you'd think, well, this is a great situation, you know, he actually found it very threatening. And the wife had disappeared. All these women were in the house. You know, what was this about? What were they going to do to him? So really a source of major concern. Now, delusions of infidelity are common. We are not naive, and we know that infidelity is common. So we check it out, but in most 85-year-olds, we find out that it's a delusion. But it's striking how common the delusion of infidelity is. It's also very disruptive for an elderly couple that's been married 55 years, and all of a sudden, one of them believes, that you're having an affair with, the 90-year-old woman who lives next door. It seems very unlikely, but these are absolute convictions that are held by patients. And then a picture sign, which is the belief that someone who is on television or in a magazine is actually in the house, actually participating there as a part of your ongoing life. And again, you can imagine how terrifying it would be to have Bob Dole suddenly appear in your living room. All right, well, delusions have special meaning in Alzheimer's disease. One of the things that's very interesting that is as yet unexplained, but it is quite clear that patients who are delusional have a more rapid cognitive decline. This is independent of treatment, and they also do not die sooner. But they lose cognitive function much more quickly than patients who are not delusional. It's one of the reasons we believe that this is a separate biological subgroup within the Alzheimer's disease diagnostic category. You tend to see them when this cognitive deficit is more severe, so they're more common late in the illness than they are earlier, and they precipitate earlier nursing home placement. If you ask caregivers or look at caregivers' patterns, they don't put Dad in the nursing home because he's asking the same question again and again. That's inconvenient and frustrating, but it doesn't cause nursing home placement. What causes nursing home placement is striking out, accusing them again and again of infidelity. It's aggression towards the caregiver. That's what causes people to go into the nursing home. And so these delusions actually are driving a lot of caregiver concerns and a lot of caregiver behaviors, as well as a lot of the expense of the illness, because nursing home nursing home placement signals the most expensive portion of an Alzheimer's disease patient's care. How common are they? They're extremely common. Longitudinal studies suggest that between 30 and perhaps as high as 70% of Alzheimer's disease patients will become delusional at some point in the course of their illness. And we did a study, just published, in fact it's in your packet there, where we asked just about the past month. And among 50 Alzheimer patients, 22% had had a delusion just in the past month. These are outpatient Alzheimer's disease patients. So this is a very common phenomenon. And when you think that there are about 2 million Alzheimer's disease patients in the United States, and half of them will be delusional at some point in the course of their illness, it means that Alzheimer's disease is the second most common psychotic illness in the United States, second only to schizophrenia. And yet we have very little research devoted to this disorder compared to schizophrenia. So again, very common and emphasized at this point. Now, a common assumption is that for some reason the delusion is a manifestation or a reaction to the cognitive deficit. We have data that suggests that that is not the case. We matched patients we looked at patients who had delusions and compared them with patients who did not have delusions. And then we just looked at whether there were systematic cognitive differences between the two. And there was no difference in learning or recall, no difference in naming, no difference in constructions, no difference in verbal fluency, which is kind of like the task that Dr. Small just described, and only a small difference in abstractions, which would disappear if you adjusted for the multiple tests that we did. So we do not find that there is a cognitive pattern of the delusional patients that distinguishes them from the non-delusional patients. It's one of the reasons, again, that we think that delusions are a primary expression of the nervous system disease and not a reaction to the cognitive deficits that are ongoing. We've also used the Behave AD to compare delusional and non-delusional patients on hallucinations, activity disturbances, aggression, diurnal rhythm disturbances, mood abnormalities, and anxiety. And the two significant correlations that came out were activity disturbances and aggression. Again, reinforcing the point that these patients are not just benignly diluted. They are patients who are active, who are carrying on purposeless activities, searching the house for the person who's hiding there, checking the locks. They're aggressive towards the caregiver. This is the real problematic subgroup of Alzheimer's disease patients who require management. Now, I just want to point out one metabolic factor that we've been looking at, and this is work primarily by Dr. Mahler and David Sulzer. Here is a PET scan of a patient with Alzheimer's disease, a non-diluted patient, and you see here the classical reduction in metabolism at the junction of the parietal lobe to the temporal lobe. So that these scans represent the glucose metabolism of the brain, positron emission tomography, or PET scans. And the areas that are red and yellow have good metabolism, and the areas that are green and blue have very low metabolism. So what you can see here is that the frontal lobes look terrific, the deep structures look pretty good, the occipital cortex is terrific, but this junction between the temporal lobe and the parietal lobe is characteristically reduced in its metabolic activity because that's the area of the cortex in the Alzheimer patient that has the most intense changes. Okay? So this is the classical AD scan. Now there are another group of patients who when you scan you see a slightly different picture. Now here is a normal elderly control, and here's a patient with Alzheimer's disease, and you see the characteristic reduction in temporal parietal metabolism here, just as we've just described. But notice also what's going on in this scan, that there's a tremendous reduction in the metabolism of the frontal lobe. And it is this group of patients who have the frontal and temporal lobe involvement that tend to be preferentially diluted. So that when we looked at correlational analysis between the presence of psychosis and the metabolic activity of regions of the brain, what we find is that those correlations are strongest for the frontal lobe and the temporal lobe, and there's hardly any correlation at all. In fact, it's minimally negative correlation with metabolism in the parietal lobe. Yet it is the parietal lobe which has the most intense change in Alzheimer's disease. So what you see is that it's the change in metabolism of the frontal and temporal cortex which is making the patient vulnerable to the occurrence of a delusional disorder. So it's the frontal and temporal changes that drive the delusional disorder in these patients. Again, why we think that it's a metabolic or biological subgroup within Alzheimer's disease. Now, Dr. Sulzer also did this scan, which I think makes a fascinating story. This is a delusional patient right here before treatment with an antipsychotic agent. Again, you see the characteristic reduction in parietal temporal metabolism, and the frontal lobe is pretty good here, but it's not as good, for example, as the deep structures are. So there's a little frontal hypometabolism. Now the patient was treated with an antipsychotic agent, and look what happened. Absolutely no impact on the temporal parietal problem, but look how increased now the metabolism is. So as the patient responded to the antipsychotic agent, there was an improvement, a corresponding improvement in frontal lobe hypometabolism. So when the patient had marked hypometabolism, they were psychotic. That's what we just learned, that predisposes them to psychosis. And as they responded to the antipsychotic agent, the metabolism in the frontal lobe improved. So I think this is starting to hint at what the underlying metabolism and anatomy of the delusional disorders of Alzheimer's might turn out to be. All right, I'm going to turn now to end this story just by talking a little bit about our work with cholinergic agents. Again, this was partially done with Jill Shapiro, who's also in the audience. Sort of an embarrassment to lecture to people who already know most of the story. But you probably all know that there is a marked cholinergic deficiency in Alzheimer's disease, a preferential loss of acetylcholine. That occurs because the group of cells at the base of the brain, called nucleus basalis, or base of the brain, is affected early in the course of the disease, and these cells manufacture the enzymes necessary to make acetylcholine. So these cells die, and the result is there's no synthesis of acetylcholine throughout the rest of the cortex, and the patient becomes acetylcholine deficient. This interesting to us was the distribution of this loss of acetylcholine, that it is not diffuse. It involves this parietal cortex where we know the changes are most intense, but it also involves the temporal cortex and the frontal cortex, which we have just said is very important for the production of psychotic beliefs. So we began to wonder whether it would be possible to treat the psychosis of Alzheimer's disease by giving them cholinergic agents, rather than by giving them anti-dopaminergic agents. This was an experiment that Jill and I did. Here's the rating of the delusions here, and this is the rating of the delusions right here with the circles. The patient was started out on a conventional neuroleptic, haloperidol, and you see that as that was started, the delusional beliefs came down very, very nicely. At this point, with informed consent, but not knowing when it was to occur, the patient was changed from haloperidol to physostigmine, and as the physostigmine dose was increased, the delusions continued to go down, and in fact they actually disappeared for several weeks. Now the problem with physostigmine is it must be given every 2 hours, okay? Not a very convenient agent. So at this point, the caregiver called us up and said, Dr. Cummings, this experiment is over. However, she was very nice, and she kept in touch with Jill, and we found out that as soon as the physostigmine was stopped, the delusions reappeared, and then we reintroduced this in an open way, and it looked like we were able to shut the delusions down or to influence them. So this was the first hint that we had that we could actually control the delusion or influence the delusion, not by giving an anti-dopaminergic agent, by giving a pro-cholinergic agent. We followed this up with a study in the nursing home, the John Douglas French Center, where we gave patients either physostigmine or haloperidol, and after 6 weeks we looked at their delusional scores again in the BEHAVE-AD. Both of the groups of patients responded very well and had an equivalent reduction. So again, it looks like by manipulating the cholinergic disturbance in Alzheimer's disease, we have about equivalent success to blocking the dopaminergic function in Alzheimer's disease. Then, of course, not long ago, Tacrin was introduced. This is a cholinesterase inhibitor. It's now available on the market, and we were interested in the behavioral response of Tacrin. And the way you introduce Tacrin, you start at a dose of 40 milligrams, and then you go to 80 and 120 and 160, and patients have a concomitant increase in their mini-mental state as you go up the dosage scale. So this is increase in mini-mental. But what was interesting to us is that at the same time, we had a progressive decrease in the behavioral abnormality score. Here we were using an instrument called the Neuropsychiatric Inventory, and a lower score means better behavior. And you can see as we march up the doses here, there's a very nice dose-response reduction in the behavioral abnormalities. Now, relevant to this was the influence on hallucinations. That is, the BEHAVE-AD allows us to look at 10 behaviors in Alzheimer's disease: delusions, hallucinations, aggression, depression, anxiety, elation, apathy, disinhibition, irritability, aberrant motor behaviors. This instrument is actually in your handout or referenced in your handout. And there was a very nice reduction in apathy, there was a reduction in aberrant motor behaviors, some reduction in disinhibition, and a reduction in anxiety. We did not see the anticipated effect on delusions. We're still trying to understand that. We had a very nice effect on hallucinations, which was not statistically significant, but at the time we did these analyses, we only had 3 patients who had hallucinations at the time that they came in. So we think that we're convinced now that this will be a robust effect. So at least one part of the psychosis is also responding to Tacrin therapy. So we're continuing to pursue this. There are more cholinergic agents that are coming onto the market. You're going to see these introduced probably this year. Many more patients with Alzheimer's disease are going to be on these drugs, and we're going to know more and more as time goes on about the behavioral response to this particular type of drugs. Now I want to just move ahead so I can make sure that we have enough time for questions, and really the crux of what I want to finish on has to do with how do you treat the elderly patient who has a psychotic disorder. And first of all, in the do-tos, you're responsible for treating the underlying disorder. All right, if that's a metabolic disorder, you've got to treat that. If it's amphetamine withdrawal, you've got to handle that. If it's a delirium caused by some sort of organ failure, you've got to treat that. So the reason that we need to identify this group of patients is because there's a whole nother dimension to treatment which is absent in the patient with an idiopathic disorder. You then have the choice of treating with a high-potency agent like haloperidol or a low-potency agent like thioridazine or Mellaril. All right? The high-potency agents have more of a tendency to produce extrapyramidal effects like Parkinsonism. They have less of a tendency to produce sedation and orthostatic hypotension. So there are fewer falls with haloperidol, there's less sedation with haloperidol, but there's more Parkinsonism with haloperidol. The opposite side effect profile prevails with regard to Mellaril. This is a drug which is very sedating, tends to produce orthostatic hypotension in falls, but produces very little Parkinsonism. Now, our choice in deciding between these, and of course there are many other agents of high potency type and low potency type, but we work generally with these two drugs. Our choice is usually to use a high potency agent like haloperidol, but to use it in very low doses, like 0.5 milligrams per day, in order to try to avoid the Parkinsonism, but also to avoid the sedation and the hypotension. Because what you don't want is to treat the patient and then have them fall down and break their hip because they have orthostatic hypotension. So very important to think about these side effects as a drug is chosen. Now we have two novel antipsychotics which have been added to our repertoire of drugs that are available. Both of these drugs are notable for their low tendency to induce extrapyramidal effects. That's why they have gained popularity. Risperidone is a drug which what can I say about it? It has a unique dopamine blocking profile and also is a serotonin antagonist. And it's thought that some of its tendency to produce very low levels of extrapyramidal effects is because of its anti-serotonergic properties. Clozapine is a drug which has even less of a tendency to produce extrapyramidal effects, but it has a tendency in 1% of individuals to induce aplastic anemia. I'll come back to clozapine in a minute. I think you got all those side effects. Let me just make sure that... So the side effects we're worried about are hypotension and falls, sedation, Parkinsonism. Should make the point that tardive dyskinesia is equally equivalent with high potency and low potency agents. There is no advantage to using Mellaril over haloperidol when you're thinking about the long-term risk of tardive dyskinesia. They appear to be equivalent. Now turning to clozapine, which is the new agent that we've been using and is particularly useful in the psychosis of Parkinson's disease. This is a novel antipsychotic that produces a little EPS because it has very little effect on D2, that is dopamine 2 receptors. And it appears that among the several types, the 4 types of dopamine receptors that are known, the extrapyramidal effects are produced by one set of those receptors, which is the D2 receptor. It blocks D1 and D4 receptors, and interestingly enough, these are preferentially distributed in the limbic system. So it's more evidence that the psychosis is generated by the limbic system disorder, and clozapine tends to get right into those receptors that are most of interest. And then in addition, it's a 5-HT2 serotonin receptor blocker, which accounts for some of its unique properties. Now, it produces some degree of sedation, which is why we start at these very low doses of 12.5 milligrams. That's a half of a 25 milligram tablet. Has to be broken in half. Start higher, and the patients will get very sedated. It produces, oddly enough, salivation. This is odd because it's an anticholinergic drug. You would think would produce dry mouth, but one of its unique properties is to produce hypersalivation. It can produce tachycardia, about 15 or 20% of patients, and 1% get aplastic anemia. That's why the patient must have a CBC submitted to the pharmacist each week before the pharmacist releases the new prescription for the next week's dose of clozapine. So it is a very, very tightly controlled drug, and you really have to have a program for this. We, for example, have patients that we see only on Mondays in Diane Christine's clinic, where we handle all of our patients who are on complex medications, and that includes Tacrin because you have to follow the livers, and clozapine because you have to follow the marrows. So we have a special circumstance to manage complex drugs, and that's what you have to have because this drug is very, very tightly controlled, and for good reasons. I will say that there's a drug called olanzapine, currently already submitted to the FDA by Lilly, which has essentially the same therapeutic profile as clozapine and does not produce aplastic anemia. So we think that olanzapine will be a very helpful addition to the therapeutic armamentarium by the end of this year. So let me just summarize what I want you to take away from this lecture. First of all, that when seeing a psychosis in an elderly individual, you need to consider diverse etiologies, which includes some late onset idiopathic disorders like paraphrenia, but more likely toxic and metabolic disorders and neurologic disorders. Alzheimer's disease being a good example of a disease which can present with a psychosis. We have treatment which is available, and there are more and more types of treatment which are available as we come to understand the actual pathophysiology of the brain changes that underlie the psychosis. But all of these treatments come at the expense of side effects, and it's the responsibility of the prescribing clinician and of the team that's working with this patient to be aware of these side effects and to monitor them very carefully. I'll stop there. Thanks. I'm just a minute over time. I see Steve is here. Maybe I can take one question. One urgent, burning question. Yes. Yeah. The question is, what about the nature of the hallucination? Does it help you decipher the underlying brain disease? The general answer is not dependably. A more specific answer is, it's interesting how often specific diseases produce specific kinds of hallucinations. And it is common in withdrawal, for example, to have formication hallucinations. This is the famous cocaine bug. Is a formication hallucination in which the patient feels things crawling on them. It's very unusual in other kinds of withdrawal settings, although it does occur. That's why it's not quite specific. Lilliputian hallucinations, or little people, tended to be characteristic of hallucinations in patients with Parkinson's disease. Kaleidoscopic hallucinations are, of course, famous for their occurrence in LSD-induced hallucinations, and that's rare in other kinds of hallucinatory circumstances. So you can get a clue, but it lacks firm diagnostic specificity.
I'm going to explain myself by saying I'm coming to you today, in my view, as kind of an expert to be. And what I mean by that is that the topic that I'm going to cover, namely anxiety and depression and alcohol use disorders in primary care patients, to my mind, there is a lot of data, but it's very amorphous, and the borders of our subject is not well defined. I don't trust a lot of the numbers that are extant. I also know that parts of my subject have been touched upon by a couple of people today and others to come, so I'm hoping that this will try to integrate. What I want to talk to you about is, and I'll try to focus how I think in 1996, and I think certainly the VA people here know how rapidly things are changing. So for VA people, I should say as of May 1996, because in 2 months we all know things may be very different. But I'll try to present an approach that I hope will be helpful for our patients. And I'll talk to you about how I think we're going to resolve our issues in the future in this area. I'm going to speak to you, of course, from a psychiatric perspective. And one of the contributions that I think psychiatry has made that resonates well with geriatrics is what we call a multi-axial diagnosis. I may slip today and refer to these axes, so I thought I'd warn you up front. There are 4 large domains that are covered by this system, and I think the general goal of geriatrics has been to look at people in a multimodal fashion. But the 4 domains are psychiatric, medical and surgical, psychosocial, and then to look at the overall level of functioning. Now, because we invented the axes, psychiatry took 2 of the axes, so there's actually 5 axes, but they cover these 4 domains, and I'll try to refer to them in that order. My presumption is that in evaluating patients, one is going to focus on specific problems, and yet those problems exist in this multimodal context. And of course, the challenge in primary care is shifting back and forth from the specific to the general. I'm going to suggest to you that as I see it, the primary care role, the role of primary care people, physicians, nurses, and really all other staff that work in these settings, would consist of several things. These would include recognition of disorders, prevention, care of, and again, I'm speaking of what I conceive of as psychiatric disorders primarily, so care of the medical consequences of these disorders, decisions on referring and or directly treating and some combination of that. And then I would add, from my perspective, 2 additional roles, and that is, the presumption is, again, that our care is longitudinal. So one role is for ongoing follow-up and to provide a supportive environment for care that is initiated. And I think particularly in these disorders, there has to be a sensitivity to the risk of relapse, and a sensitivity that relapse is not always catastrophe, but early recognition of relapse starts the cycle over again and can be very valuable for patient care. Let me tell you quickly about Upbeat. And when we have bad days, we refer to it as Beat Up, but that's a separate issue. And Upbeat is a project which I hope will lead me to be a more suitable expert for you in a year or 2 as we learn about it. Upbeat actively screens patients that are inpatients for symptoms of anxiety, depression, and alcohol use disorders. We evaluate patients. We enroll patients in a case management program and provide psychiatric treatment as appropriate. We coordinate this care with primary care teams. Upbeat teams are in, as we sit here, 9 VA centers nationwide, and West Los Angeles is the coordinating center for these 9. We have a data collection system so that we can track. There are currently approximately 700 patients enrolled nationally in the program. There are 6 monthly and then annually follow-ups built in so that we can evaluate patient status and also evaluate the effects of our inputs. As that data accrues, I will feel more confident giving you real information. What I'm going to talk to you about today is my clinical experience and the literature as I see it. I want to turn first to the area of depression and anxiety. I'll risk taking the time to give you a quick clinical anecdote for a kind of patient that we see. It's a gentleman that was recruited, hospitalized for evaluation of a possible cardiac problem. Came back for evaluation, and it was an interesting interview. He's the only gentleman that I have ever met who fought against the United States in World War II, which makes it slightly difficult for him to bond with the VA in general, I think. The story is that he later, that was as an adolescent, and he then came to the United States and became a naturalized citizen. He's a legitimate VA patient, but it's tricky. The interview was interesting, and it really didn't uncover psychopathology, and this was a fairly long interview. He actually was interested in a fairly elaborate process and explained it, but I was ready to conclude that we did not have an active problem when it turned out that he was not living at home. He was in the midst of a terrible marital disruption, and he was completely alienated from his family. And in fact, the index hospitalization had happened as he was discharged from jail. He had had a panic attack and went straight to the VA emergency service and was admitted. These are the kinds of overlaps that we see. Now, I can't tell you the outcome of this one yet, but these are the kinds of problems that I think one has to be aware of in this interplay between soma and psyche and situation. And in fact, this gentleman was at extraordinary risk for potentially doing something very desperate or really having his life decomposed in a very serious manner. With that introduction, I want to talk to you a little about depression and anxiety. I realize this doesn't follow the outline that I gave you precisely, and one of the reasons is that it becomes increasingly difficult in this patient population, I think, to separate depression and anxiety. When we screen patients for depression and anxiety and alcohol, over half the patients are positive for both depression and anxiety. It's by far our largest patient group. And even in the ones who don't meet screening thresholds, it is very hard to find a case of pure depression or pure anxiety. So I'll focus on depression in particular and suggest to you that in this population there are specific triggers that indicate a risk for depression. The biggest and most consistent in the literature is social isolation. If you do statistical studies, it turns out that if you have a measure of medical illness severity, that correlates with the risk of depression. Histories of substance abuse, a history of severe depression in the patient or in a family member, I think are very significant. And in many cases, this will not have been identified as such. We'll talk about screening in a minute, but the term depression means different things to different people. And so I find that I probe for that by asking a more general question. I ask if someone has ever gotten to the point where they felt like they couldn't cope. And I find that elicits more episodes of what I think in retrospect are serious depressive episodes, but they were never identified as such by anybody. Now, in the literature, there are several other issues which I question, but I have to present them to you. There remains, even in elderly populations, a statistical preponderance of females among depressed samples. I'm not so sure that isn't an artifact of several things. There is a rich clinical lore suggesting that patients with early progressive cognitive dysfunction, Alzheimer's disease, other dementias, are treated as depressed patients. Now, there's a different discussion as to whether we call this depression or not, but in a sample of seriously depressed elders, a percentage of those patients will be recognized as having a significant dementia 2 or 3 years down the road. The effect of age itself is very controversial, and one reason I'm not quoting numbers to you is that all of the surveys that have been done are subject to important population biases. If you do door-to-door surveys, you miss a significant percentage of older folks. You miss, of course, patients in long-term care, and so I think your numbers are really dependent on setting. Now, there are two other major reasons that I think in primary care one has to be concerned with recognizing these disorders. The first is that it is now recognized that depression is probably second only to hypertension as a reason for patients to visit medical care facilities in this country. I actually did my internship in medicine, which contributed to the problem that Dean identified, I think. And it was in a hospital that didn't have a formal psychiatry program, and so I was on the defensive to some extent. But I realized, asking the attending physicians, that most of them admitted that half of their patient population saw them for depression and anxiety. And so at that point I decided that 50% of all physicians, if the world were rational, would be psychiatrists. That, of course, hasn't happened. It is now recognized that depression causes as much disability as other chronic illnesses. In fact, higher levels of impairment in patient function are associated with depression as compared to chronic arthritis, hypertension, or osteoporosis. A third reason is that it turns out that there is, to me, still a surprisingly large effect of depression on prognosis. Again, this is a large literature. I'm going to quote you one illustrative study. This is a prospective study of 222 patients admitted to hospital and diagnosed with acute myocardial infarction. These patients had a structured interview by a non-clinician, which generated a presumptive diagnosis of, or non-diagnosis of major depression. And it turned out that 16% of these patients, 35 of the 222, were felt to meet criteria for major depression at this hospitalization. At follow-up 6 months later, it turned out that the presence of major depression was a risk factor for mortality of between 3 and 4, just about 3.5. Unexplained by the severity of their cardiac disease. It was a bigger predictor of death than was the presence of arrhythmia, the size of the infarct, the cardiac status, the functional status that emerged after the heart attack. That is a prospective study that supports a whole series of retrospective reviews. And it is not clear what mediates this effect. The main suggestions divide into psychologic and physiologic explanations. I don't think we have time to go into those here, but it's a major effect. I have to say that it is not clear whether treatment will affect this or not, and programs like Upbeat may show this. One of the interesting things about this is that of these 35 patients with major depression by standard interview, the clinician only recognized depression in 17, enough to refer. 3 of those patients were diagnosed and received treatment. So that's consistent with the under-recognition and under-treatment that is in general. Okay, the major task then is to recognize the importance of this and then recognize who's depressed, and the question is how to do that. My answer is I'm not exactly sure how you do that. My advice is that you ask. And there are a variety of screening tools, and I think it is appropriate to consider incorporating a standard rating scale for depression. In the UCLA Geriatrics service, the most popular is the short form, the 15-item geriatric depression scale. There's a 30-item version. At Century City, for a while we used the Zung, and that patrons of the Zung in the back of the room here, Dr. Wong. The Beck Depression Inventory is used. My personal feeling is that it doesn't really matter which one you use as long as you do 2 things. One is that you ask. 2 is that you listen to the answer. And what I mean by that is the gentleman that I presented to you at first here was someone who really denied having much psychiatric distress. It wasn't until one listened to the anguish that came out of him, which was expressed in a variety of other terms, that I realized what I was listening to. So the listening, it's helpful if patients admit that they're depressed. That's certainly true. And that's a good prognostic sign, in fact. But they won't always. And in a primary care setting, as we'll discuss a little bit more later perhaps, you have patients who complain of pain, general discomfort, and are unhappy and are even more perversely may be unsatisfied when you have done something that is apparently beneficial. Okay? That benefit is not apparent to them. That's a depressive reaction. We'll talk about cognition. The cognition of depression is a major issue. And these patients can be very frustrating until that is recognized. So for everyone's sense of well-being, it's a good thing to do. The most specific syndrome, the one that is most clearly, The syndrome that most clearly benefits from treatment at this point is a syndrome we call major depression. And I believe you've seen criteria of that today, but I want to review that quickly. It doesn't take long to review these with patients. You only have to ask about 9 items. Turns out officially if they have 5 of them for 2 weeks or more, then you diagnose major depression. And these are the 9 items. 1, are they depressed? Now, they don't have to be depressed. If they're not depressed, though, they have to have a quality that we call anhedonia. They do not experience pleasure. They do not experience benefits, and that's related to the issue that I spoke of a minute ago. Ask about weight loss, insomnia. You observe whether there is restlessness or a curious kind of inactivity. The technical terms for those are psychomotor agitation and retardation. The retardation is a very distinctive quality that is this sitting in place and a feeling of leadenness, a reluctance to move easily. Patients will complain of fatigue and loss of energy, and of course that's a common complaint in many clinics. There will be a sense of worthlessness and or an experience of guilt. And the guilt, of course, would be considered inappropriate to whatever. There are things that's appropriate to feel guilty about. This is inappropriate guilt. The patient may demonstrate or complain of a diminished ability to think or concentrate. That, of course, brings up the differential issue with memory disorders in general. An important issue is recurrent thoughts of death or suicide. And the statistics on suicide in the elderly are very sobering, but the major one is that 3/4 of elderly patients will visit their primary care doctor within a month prior to committing suicide. And in many cases, it's felt that that's an opportunity to identify and perhaps save people. In reviewing symptoms and diagnoses, there are other possibilities. One is that the patient may be depressed but may not meet criteria for major depression. The depression may be felt to be a direct result of either a substance abuse disorder, such as alcohol, or a primary medical disorder. There may be other symptoms, particularly of anxiety, panic, obsessions and compulsions, specific phobias, which may occur separately or may exist along with depression. As I said, most patients with anxiety will have depression. It's always important to ask about substance abuse, but particularly in patients with mood disorders, the presence of substance abuse affects treatment, and it certainly affects prognosis and is a major risk factor for suicide. So an important issue to cover with everybody. And of course, one has to be knowledgeable about concomitant medical disorders and at least ask the question about a concomitant cognitive impairment, which may raise questions of dementia. Now, referring and treatment. And I think this is an area that depends very much on the setting that one works in. Some of my colleagues are projecting that in the future geriatric psychiatrists probably won't see patients, but will be very high-level consultants. This is hard for me personally to envision, but I'm warning you that that's what some people expect. It is the linkage between mental health care and primary care is something that, of course, is being worked out. And the expectations for how much direct primary care people will be involved in mental health care, I think, is also being worked out. I think there are 3 domains of affective disorders which have to be considered in the care issues, though. And medicines will respond to a fraction of these at best, even when they're successful. So I think the emphasis is that a care plan has to be multidimensional, responding to the same axes that we talk about: psychiatric, medical, and psychosocial. Specifically, psychiatric medicines can be extraordinarily helpful in terms of alleviating the somatic expressions of mood disorders. You can improve sleep, appetite, habit, activity, and mental alertness. They don't work for everybody, and there is the textbook situation at this point is that the frontline drugs are, this is actually for VA people a little bit challenging. At our station, the pharmacy has decided that physicians, when prescribing antidepressants, need to prescribe either a tricyclic antidepressant or trazodone. I think the community standard is that the serotonin reuptake inhibitors are the frontline drugs because of the decreased risk of side effects in them. Reviews of this subject of treating elderly patients actually suggest that the incidence of side effects is somewhat equivalent between the two groups of drugs. But in any case, medication is a primary consideration, and choice of medicines depends on, for me, on what my relationship with that patient is, how closely I'm going to follow them up, medical condition, side effects, and particularly their previous experience. And often you get a sense from patients which kinds of side effects are intolerable for specific patients. The upshot is that I still use tricyclic antidepressants at a higher rate than I do serotonin reuptake inhibitors, but I'm also in a situation where I'm referred to people who have failed their first frontline treatment, which most typically is Zoloft, Paxil, or Prozac. So I'm not sure my experience is something that you should do. Prognosis in depression is crucially dependent on psychosocial setting. And it is important in general to know, but it's specifically important in mood disorders, always to know the situation of your patient. Recent bereavement is a particularly high risk factor for depression that is hard to treat, and it's the depression that will not simply be treated by medication. The other dimension to depression treatment that I think we don't have enough trained people to do, but is important for truly successful treatment. And successful treatment means returning people to high levels of function. Antidepressant medicines can, in many cases, be helpful, again, in alleviating the acute physical symptomatology. But too often you're left with a patient who doesn't feel actively depressed but isn't very active. As it turns out, I'm functioning as an expert witness in a case where that is exactly the charge, where the patient is now alleging that a previous course of treatment was inadequate, admitting that the treatment was better, made her better, but left her inadequate, and when she changed treatment regimens, she got a lot better. This dimension can be approached in specific ways, but it falls under some form of psychotherapy. To some extent, this can be done within the supportive environment of a good primary care clinic, and so the quality of contacts with everybody is very important. Many patients will benefit from a focused psychotherapeutic approach, and the most direct assault on these kinds of questions is an approach called cognitive behavior therapy, which actively tries to reteach depressed people. And I say reteach because I think people that suffer long times of depression in their lives learn in an unconscious way that the world is an unfriendly place, and it takes a while to unlearn that. They develop reaction patterns which are based on that presumption. The pessimism, the negativism, the hopelessness, the inversion of cause and effect that they experience need to be actively dealt with. Now, these are issues that I think it's very important for primary care teams to be aware of, and they can make interventions, not lengthy interventions, but comments to counteract that. But to actively work on it in a conscious way, I think, takes a more focused approach and means referring. It obviously will work best if the mental health treatment team and the primary care team are in good communication. I need to move on to alcohol, but I wanted to mention one last issue, which I think that I encounter a lot in my patient work, and it usually reminds me of the story of Gilgamesh, and I won't retell that story now, but Gilgamesh is the primary story where a hero, in response to a sense of mortality, seeks out the secret of eternal life and almost gets there, reaches for the lotus, which is in the pool in the cave, and then something happens, and the lotus disappears, and he misses his chance forever. And at that point, Gilgamesh recognizes that he's going to die, and the rest of the story extends from there. The reason that that story echoes so loudly in my experience is that our patients, we live at a time where the very success of medical care has contributed to people's denial of death. And a diagnosis that awareness of impending mortality can come at a variety of times. It's an issue that will come up, and that epiphany will occur to people in your waiting rooms. And not to be aware of it is a tough thing. And I wouldn't suggest that there are easy answers to it, but knowing that your patients are struggling with it is an important issue. It's enough to drive you to drink sometimes. And I will make some comments on alcohol use, misuse, and abuse. I'm indebted to this perspective primarily to my colleagues from a cousin or sister or brother program at the Veterans Hospital called Get Smart. And Get Smart is a program which was set up to look for medication and drug and alcohol problems in elderly patients, particularly in conjunction with medical illness. Analogous to Upbeat, recruits patients, also takes referrals. One of the findings that, and West Los Angeles, we have to understand, is a facility with, in terms of resources in a big sense, has a lot of psychiatric care to offer. There were very few treatment options available for elderly substance abusing patients, and Get Smart ended up finding that they had to do they were not able to triage, had to do treatment in a primary sense. So if that problem is true at West LA, this is a general community problem. The size of the problem is still under some debate. Part of the difficulty is definitional. We have drinkers, there's a lot of people drink alcohol in this country, and one question is, when does that become problematic, and how do you define it? There are problems, again, with setting, and there are problems with deciding when someone's old or not. So there are surveys that look at people over 55, 60, 65, 75, etc. So generic numbers give you a wide range. Community prevalence statistics suggest that of people over 60, somewhere between 2 and 10% might be said to have an alcohol problem. When you inquire into those people, it turns out that it's generally true that about 2/3 of them have their alcohol problem before they got old, and 1/3 of them are what is called late onset. They acquire this later in life. The known risk factors except for being an alcoholic before you get to be old, but the known risk factors for being an older drinker are, again, still being male. Although, again, I think there's an artifact here. It's simply, in many circles, it's still unwomanly to be a drinker, and so women are not asked as much. And when I ask, I find that there's a lot more women drinkers than I thought there were. But officially, males are still at higher risk. Interestingly, people with more money and more education are more at risk for drinking more. And so one comes to meetings and hears about the typical VA patient who lives in a hotel downtown as a drinker, but that is not the typical elderly alcoholic. Social isolation, however, is also a risk factor for drinking. It isn't clear whether, in some cases for the late onset patients, that is the risk factor. In other cases, of course, the alcoholism earlier in life contributes to social isolation. Medical utilization consequences are substantial. I think everybody has a sense as to the numbers of patients And the literature suggests that there are as many admissions to hospital in this country for alcohol-related illness as for myocardial infarction. And that's a staggering figure. It's estimated that alcohol contributes to 6 to 8% of acute medical admissions in the elderly, and perhaps as many as 20% of acute psychiatric admissions. In my experience, frankly, that latter number is a little elevated. One interesting fact is that a recent study suggests that the major effect on mortality among drinkers is actually due to their concomitant cigarette smoking. And it turns out that it's very hard to find alcoholics who are not cigarette smokers. If one wanted to study that group, that's not an area to get into. And the relationship of alcohol and aging is, again, surprising. Turns out that unless you're ill, that you metabolize alcohol at about the same rate up into the 80s as you do when you're younger. What does change is that the body composition changes so that for any given amount of alcohol that you take, your blood alcohol concentration is higher. To remind ourselves that there's a general shift in bodies so that we have relatively more fat as we get older. And alcohol is distributed in the water part of the body. Now, recognition again, and for me the principle is the same. The principle is you ask. The most popular standardized screening is called the CAGE. Has anybody not heard of the CAGE? How many people don't remember what the 4 things stand for? That's okay, I don't always remember, so the 4 are the CAGE, of course, that's why we call it the CAGE. And the 4 questions are, have you felt that you should cut down, that's the C. Have you found that others are annoyed by your drinking, that's A. Have you ever felt guilty about having a drink? And the last one is, have you ever felt the need to have an eye-opener in the morning, a drink to get you up when you get going? There are other screening questions. My sense of the problem with older patients is not that. If you ask, people will tell you how much they drink in most cases. And you can ask with the CAGE, or you can just ask people. The bigger problem in primary care geriatrics, in my experience, is people who have been well-contained social drinkers who have a change in their health status where the drinking becomes problematic. And education about that is a major issue. The famous Get Smart story is the fellow who came into the hospital, had phlebitis, was put on Coumadin, was carefully instructed that you cannot drink when you take your Coumadin. And so he carefully went out and took his Coumadin every morning, and he carefully waited until 4 o'clock every afternoon to go to the bar, and felt that he was complying with the directions that had been presented to him. And of course, the metabolism of Coumadin, which is not a trivial issue, went haywire. I didn't talk about prevention and depression very much, but there are some preventive aspects of alcohol, which again, primary clinics I think can be well attuned to. First is I think that we do underestimate how important continual reminding and education is for patients. Patients come in and in most cases are receptive and respect information that they will get in that setting. And so availability and repetition of information about the seriousness and the problems of drinking with an accessibility for people that might want to hear more about it, I think is a crucial role. Again, how much a primary care clinic can do, I don't know, but to be aware of this factor of social isolation, both for the mood disorders and drinking, is a very important issue. And so you have to have that ear more finely tuned for those patients at a minimum. And a related issue is to be available and aware of changes in life status. I've referred to what I see as the crucial role of bereavement. And again, in Of course, bereavement is statistically more commonly a female problem than a male, but there are a fair number of people whose lives, they don't stop, they slow down a lot after the death of a spouse. And one solution to that, especially when you're having trouble sleeping, of course, is to start drinking. A secondary role of prevention, again, is recognition, referral, etc. A tertiary role, and again, one that I think is crucial for long-term care in primary care settings, is that to interact continually with the treatment team and to be aware of relapse once someone has established sobriety or euthymia, as the case may be. Now, treatment in alcohol, again, I only have time to go through some basic principles. I'll divide them again into non-medical treatment and medical, emphasizing that the cornerstone of treatment is still psychosocial. So referral, support, counseling are vital. And it's important to identify a referral source that is familiar with, knows, and will work with older patients. It simply does not work very effectively to refer older patients to a program that treats predominantly younger patients. And if they aren't there, then you have to harass them to develop such a program that's specific. And fortunately, increasingly more are available. There is some preliminary data to again suggest that focused, problem-oriented types of psychotherapy, such as cognitive behavior therapy, can be specifically beneficial. Now, I'm presuming that someone has been able to detox, and I've kind of glossed over that. And of course, in a few cases, one will have to make an evaluation and refer for acute detoxification treatment. Now, there's been, of course, a lot of interest in medications that might prevent or compensate for alcohol deficits. And there are three types of medicines that have been used. The famous one, of course, is antabuse. This is an aversive medicine. You take antabuse, and if you drink, bad things happen, and you feel pretty crummy. The problem, of course, is it's easy not to take that antabuse pill. And the reality is that some drinkers drink right through the antabuse. So a bad drinker will not be slowed down by antabuse in any way. And of course, a lot of this treatment is done by psychiatrists. What brings people into treatment, of course, is feeling bad. That looks like depression. It looks like anxiety. There, in fact, is a lot of concomitant depression and anxiety in alcoholics. There's another ongoing debate in my profession about how much of that is caused by alcohol or how much of it causes the alcohol use. And it's one of the more sterile debates that I found. That the answer is yes, all of that's true. For alcohol treatment, the important issue is that psychotropics aren't terribly effective at reducing alcohol use. There is some evidence that depressed patients who are drinkers, when you treat the depression successfully, they are unlikely to relapse, and that a relapse in their alcoholism goes along with a relapse in their mood state. But that's a relatively small group. And so there are studies of specific antidepressants, dizipramine, I believe, being the most popular, which are really largely disappointing. Now, there is hope on the horizon. There is, I think this is potentially one of the real advances in our understanding of not only alcohol use, but in fact of behavior in general and how we learn over time. And these are the links that have been shown between the brain opioid reward system, the brain's dopamine system, and substance abuse. The specific agent that has been effective is the naltrexone, which is an opiate antagonist, has proved impressively effective at increasing response rates in, I should say, the first-rate psychosocial treatment program has a success rate of keeping people out of serious alcohol use as 30%. That's considered a good program. If you add naltrexone to that regimen, the success rate goes up to 60%. It's 100% effect. It's a very striking thing. And this is an area that, of course, has proved extraordinarily disappointing time and time again. but this has now been replicated several times and is looking to be a more robust finding. So there may be hope for the future for those things. Finally, of course, for both these disorders, that both alcohol and mood disorders, one word is the treatment should be successful for the large majority of patients and can be extraordinarily beneficial. Primary care teams will then inherit these patients who are on treatment. All of these conditions have a significant risk of relapse, and one can't let the guard down in terms of maintaining a link to that patient and their needs. I'm going to stop here before I get signaled again, and I'll turn the program back to him.